Welcome to the Deep Dive, the show where we cut through the noise to get to the heart of what you need to know. When we think about heart problems, we often focus on the big things, like heart attacks.
Right, the common stuff.
Exactly. But imagine your heart, that incredible engine, also facing hidden dangers, invaders from within, or even its own protective shield, causing trouble. It's way more intricate than most people think.
That's absolutely right. And today, we're peeling back those layers. Our mission here is to do a really focused deep dive into two distinct but equally critical cardiovascular challenges. First, infective endocarditis.
Okay.
Which is basically an infection hitting the heart's inner lining and valves. And second, a group of conditions we call pericardial diseases. These involve the protective sac around the heart itself.
And our goal is pretty simple, right?
Yeah.
We want to cut through the medical jargon, give you the essential nuggets of knowledge so you can walk away from this deep dive feeling genuinely clued in about what these conditions are, who's most at risk, how they show up, and, critically, how they're diagnosed and managed.
Yeah, exactly. And get ready for some maybe surprising facts, some really memorable clinical signs, and just a clearer picture of why understanding these nuances is actually pretty important for anyone interested in heart health. Let's explore.
All right, let's dig into our first big topic then, infective endocarditis, IE for short. So, at its core, what's really happening when someone gets IE?
So infective endocarditis, it's basically a bacterial or sometimes fungal infection that gets a foothold inside the heart on the inner lining, which we call the endothelium, and it particularly likes the heart valves.
Okay.
Think of it like microbes often just floating around in the bloodstream. That's bacteremia finding a spot on these surfaces to colonize and set up shop, and that can be really dangerous.
So it's literally germs invading the heart's inner sanctum. And which valves are the usual suspects here, the main targets?
The mitral valve is the most common one involved. So mitral, then aortic, then tricuspid, and least often the pulmonic valve.
Mitral first. Got it.
And this is really interesting, there's a crucial exception for people who use IV drugs.
Ah, yes.
The tricuspid valve, that's the one on the right side of the heart, becomes the most common site by far.
And why is that? Just the route of entry.
Exactly.
Yeah.
The bacteria get injected straight into the veins, right? So they hit the right side of the heart first. Makes sense pathologically.
That makes perfect sense. A really vital distinction. So, okay, beyond IV drug use, what else makes someone more likely to get IE? What are the risk factors?
Well, you can think of risk factors as things that either weaken the heart's natural defenses or introduce something foreign that bacteria can grab onto. So we see more risk with increasing age, especially over 60.
Okay.
Also a history of rheumatic heart disease, conditions that suppress the immune system.
Right.
Having prosthetic heart valves is a big one.
Right. Artificial material.
Exactly. And certain types of congenital heart disease, too. They all kind of open the door for these microbes.
And what about the microbes themselves, the actual culprits? Are there specific germs that cause maybe different types or severities of endocarditis?
Absolutely. We often group them by how aggressive they are, their virulence. So you have highly virulent bugs like Staphylococcus aureus, which, by the way, is the most common cause overall, including MRSA.
That's aureus. Okay.
These guys are tough. They can infect even healthy, normal heart valves. And they tend to cause acute infective endocarditis, comes on fast, can be really severe.
Wow. And the others? Less aggressive ones.
Then you have the less virulent organisms like Streptococcus viridans. These are more opportunistic. They usually need a valve that's already damaged to get established.
So they need a weak spot.
Precisely. And they tend to cause subacute infective endocarditis, which develops more slowly, kind of smolders.
So S. viridans exploits a weakness, while S. aureus is more like a direct assault, even on healthy tissue.
That's a good way to put it, yeah. And S. viridans, interestingly, is often linked to bacteria from your mouth.
The mouth. Like poor dental hygiene.
Exactly. Poor dental hygiene, gum disease, gingivitis, or even just, certain dental procedures can let these bacteria slip into the bloodstream. And then they go looking for a vulnerable spot on a heart valve.
That's fascinating. Are there other specific bugs tied to particular situations that might be surprising?
Oh, definitely. For instance, if someone gets i.e. say within about 2 months of getting a prosthetic heart valve.
Okay, early on.
Yeah, early prosthetic valve endocarditis, that's often caused by Staphylococcus aureus again, or another one called Staphylococcus epidermidis. We also see Enterococcus species.
Enterococcus?
Right, especially in men over 50, often linked to recent GI or urinary tract procedures. And then there's this whole group called the HAC organisms.
HAC. What's that stand for?
It's an acronym for a bunch of gram-negative bacteria. Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, Kingella. The key thing about them, they're notoriously hard to grow in standard blood cultures.
Ah, so tricky to diagnose.
Very. So if the blood cultures keep coming back negative, but the clinical picture screams endocarditis, doctors start thinking about HAC.
Now, what's really fascinating, I think, is how some of these tiny culprits can actually point to bigger problems elsewhere. You mentioned Streptococcus bovis before.
Yes, that's a fantastic example of medical detective work.
Mm-hmm.
Strep bovis is a common bacterium in the gut, normal, harmless there.
Right.
But if we find strep bovis causing endocarditis, it has this surprisingly strong link to underlying colorectal cancer or even ulcerative colitis.
Wow, so finding that specific bacteria triggers another investigation.
Absolutely. Finding strep bovis endocarditis is often a direct recommendation for the patient to get a colonoscopy. It's a really powerful diagnostic flag for a potentially hidden serious condition.
That is genuinely fascinating. A tiny microbe acting as a clue. Okay, so let's switch gears a bit. What does IE actually look like? For the patient, for the doctor, what are the key signs, the symptoms?
Well, the most common thing almost always present is a persistent fever, often with chills, feeling run down, loss of appetite, maybe some weight loss, just generally feeling unwell, malaise.
Standard infection signs, mostly.
Pretty much. But another really significant finding in 85% of cases is either a new heart murmur or a noticeable worsening of one that was already there.
Indicating valve damage.
Exactly. It tells you the infection is messing with how the valve is working, causing leakage, usually regurgitation.
Okay, so beyond fever and murmur, are there those really distinctive physical signs, the kind of calling cards for IE?
Yes, there are these classic, though maybe less common, findings that we group into immune or vascular phenomena. They're really helpful clues. For instance, Osler nodes.
Osler nodes. Painful.
Painful, yes. Tender, raised, purplish bumps, usually on the finger or toe pads. Then you have Janeway lesions.
And those are?
Painless, flat, reddish spots, typically on the palms of the hands or soles of the feet.
Painful Osler, painless Janeway. Got it.
Exactly. You might also see splinter hemorrhages. Tiny reddish-brown lines under the fingernails, looking like, well, splinters.
Okay.
And even in the eyes, sometimes rough spots can be seen during an eye exam, little hemorrhages on the retina with a pale center. These are rarer but very suggestive when you see them.
Those are definitely memorable signs. And I guess, given it's an infection spreading through the blood, it can cause wider problems too.
Oh, absolutely. It's systemic. You might see tiny red dots called petechiae on the skin or mucous membranes. The spleen can get enlarged. And a really serious complication is if bits of that infected material on the valve break off.
Emboli.
Septic emboli, exactly. They can travel anywhere to the brain, causing a stroke, to the lungs, kidneys, limbs. It can even trigger inflammation in the kidneys, glomerulonephritis.
You mentioned the tricuspid valve earlier, especially with IV drug users.
Yeah.
Does endocarditis on the right side of the heart present differently than on the left?
It definitely can, yes. Right-sided IE, which again is mostly the tricuspid valve and common in IV drug users, about 90% of cases. It still usually involves fever and feeling unwell. But patients often have more prominent pulmonary symptoms. Things like cough, shortness of breath, chest pain that worsens when breathing, sometimes even coughing up blood.
So it could almost look like pneumonia or something respiratory.
Exactly. It can be tricky because it might mimic a simple upper respiratory infection or pneumonia at first, which can unfortunately delay getting the right diagnosis of endocarditis.
Right, that delay could be critical.
Yeah.
So how do doctors nail down the diagnosis then? What are the key tests, the framework they use?
Well, to really solve the case of IE, there are two main investigative tools. First, blood cultures. Absolutely essential.
To find the bug.
To find the specific culprit, yes. And ideally, these need to be drawn before any antibiotics are started. Usually 3 sets taken from different sites, at least an hour apart if the patient's stable.
Okay, 3 sets before antibiotics.
Yeah.
And the second tool?
Echocardiography. That's the ultrasound of the heart. It's like our camera inside, letting us see the valves, look for those bacterial clumps, we call them vegetations, and assess any damage.
Is one type of echo better than another?
We usually start with a standard transthoracic echo, TTE, the one done on the chest wall. But if that's unclear, or if we have a high suspicion, or especially if there's a prosthetic valve involved,
Right.
then a transesophageal echo, or TE, is often needed. The probe goes down the esophagus, giving a much clearer, up-close view of the heart structures. It's much more sensitive.
But you get the blood cultures, you get the echo results.
hmm
How do you put it all together for a definite diagnosis?
Yeah.
Isn't there a specific criteria set?
Yes, exactly. We use the modified Duke criteria. It's a well-established system that combines major and minor findings to help standardize the diagnosis.
Okay, Duke criteria. What counts as major versus minor?
So, major criteria are the big things. Basically, positive blood cultures showing a typical IE organism, or clear evidence of endocardial involvement on the echo, seeing a vegetation, an abscess, or a problem with a prosthetic valve, or developing a significant new valve regurgitation murmur.
Right, the really strong evidence.
Exactly. Minor criteria are more supporting evidence. Things like having a predisposing heart condition, or being an IV drug user, having a fever, seeing those vascular phenomena like Janeway lesions or emboli, the immunologic signs like Osler nodes or Roth spots, or having microbiological or echo evidence that doesn't quite meet the major criteria level.
And you need a certain combination.
Yes. To make a definite diagnosis, you typically need either 2 major criteria or 1 major criterion plus 3 minor criteria, or just 5 minor criteria on their own. Following this framework gives us about 80% accuracy, which is pretty good.
That makes sense. A systematic approach. So, okay, once IE is confirmed, how do you treat it? And maybe just as important, can it be prevented in high-risk folks?
Management-wise, the absolute cornerstone is antibiotics, often started empirically, meaning based on the most likely culprits, even before the exact bug is identified from cultures.
So what would that initial treatment look like?
Well, if you're suspecting MRSA, or you just don't know the organism yet, a common choice is vancomycin, maybe combined with another antibiotic like ceftriaxone or gentamicin, depending on the situation. If it turns out to be MSSA, the type of Staph aureus that's still sensitive to methicillin, then a specific anti-staphylococcal penicillin is usually preferred. Daptomycin is an alternative if someone can't tolerate vancomycin.
Now, this brings up a really important point.
Yeah.
What if the infection is actually on a prosthetic valve? Does that change the treatment plan significantly?
Oh, absolutely. Prosthetic valve endocarditis, or PVE, is notoriously harder to treat. Bacteria just love to stick to foreign materials, forming biofilms that are tough for antibiotics to penetrate.
Makes sense. So a different strategy.
Yes, typically a more aggressive combination therapy, often vancomycin plus gentamicin, plus another drug called rifampin.
Rifampin, why that one specifically?
Rifampin is really good at killing Staphylococci that are stuck, adhering to foreign material like a prosthetic valve. It helps clear the infection from the device itself.
And what about fungal endocarditis? You mentioned that earlier.
Fungal IE is rare, but very serious and challenging. It usually requires long courses, like 6 weeks or more, of potent intravenous antifungal medications, and often surgery is needed to actually remove the infected valve and the fungal growth.
Wow. So general principles are long courses of targeted antibiotics.
Yeah, the key is tailoring the antibiotics once you get the culture results and sensitivities back. Treatment typically lasts for 4 to 6 weeks, sometimes longer for complicated cases or PVE. And it's good to know that fever can actually persist for up to a week, even after starting effective antibiotics. So that doesn't necessarily mean treatment failure right away.
Okay, 4 to 6 weeks of IV antibiotics generally. Now, what about prevention? Prophylaxis. Who actually needs it and for what procedures?
Right, prophylaxis. This is giving antibiotics before certain procedures to prevent bacteria from getting into the bloodstream and causing IE in the first place. But, and this is important, it's only recommended for a very specific group of high-risk patients.
Who falls into that high-risk category?
Primarily people with prosthetic heart valves, anyone who's had IE before, patients with certain complex congenital heart diseases, and heart transplant recipients who develop valve problems. It's not for most people with common valve issues anymore.
Okay, so a fairly narrow group. And what procedures trigger the need for prophylaxis in these high-risk individuals?
The main ones are certain dental procedures, specifically those involving manipulation of the gums, the area around the tooth roots, or perforation of the oral lining. Think tooth extractions, deep cleanings, implant placements.
Makes sense, letting mouth bacteria in.
Exactly. Also, some respiratory tract procedures like inserting a bronchoscope or procedures on infected skin or muscle tissue like draining an abscess.
And the standard antibiotic.
Usually a single dose of amoxicillin taken about an hour before the procedure. If someone's allergic to penicillin, there are alternatives like certain cephalosporins, doxycycline, or macrolides like azithromycin.
So what does this mean practically? Have there been recent changes maybe regarding dental visits? I feel like I heard something about clindamycin.
Yes, that's a really crucial update from the American Heart Association's 2021 guidelines. Clindamycin, which used to be a common alternative for penicillin allergy,
Right.
is no longer routinely recommended for dental prophylaxis. This is because of increasing concerns about its side effects, particularly its association with causing severe C. difficile infections.
Ah, C. diff. That's serious.
Very. So the alternatives are now preferred. And it's also key to stress that routine prophylaxis is no longer recommended for most other types of valvular heart disease or for most routine GI or GU procedures. The focus has really shifted
Shifted towards what?
towards emphasizing the importance of maintaining good daily oral hygiene for everyone. That's now seen as the most effective way to reduce the overall risk from transient bacteremia from the mouth. Brushing, flossing that makes a bigger difference day to day than a single antibiotic dose before a procedure for most people.
That's a really practical and important takeaway. Okay, that covers infectious endocarditis thoroughly. But you mentioned sometimes the heart lining can have issues that look like infection but aren't. Liebman-Sachs endocarditis.
Exactly. That's an interesting one. Liebman-Sachs is a type of non-bacterial, non-infectious endocarditis. Instead of germs causing vegetations, you get these small, sterile clumps of platelets and fibrin, basically tiny clots forming on the heart valves, most often the mitral and aortic.
And what causes that? No infections, though.
It's typically associated with autoimmune conditions, most famously systemic lupus erythematosus, or SLE.
Lupus.
Right. It can also be seen in some cancers or in antiphospholipid antibody syndrome. Patients are often asymptomatic from the valve vegetations themselves, and they usually don't have a fever. Problems mainly arise if these little sterile clots break off and travel, causing emboli similar to infectious emboli, but without the infection.
So treatment focuses on the underlying cause.
Precisely. Managing the underlying SLE or other condition is key. Sometimes anticoagulation, blood thinners, might be considered to reduce the risk of those embolic events.
Okay, fascinating. So we've explored the heart's inner battles. Now let's pivot and look outwards to the heart's protective covering, the pericardium. What happens when that area faces problems? Let's talk pericardial diseases, starting with acute pericarditis.
Right, so acute pericarditis is simply inflammation of the pericardium, that thin two-layered sac that surrounds the heart.
Just inflammation of the sac. What usually causes it?
In many cases, probably most in developed countries, we actually label it idiopathic, which just means we don't pinpoint a specific cause. But it's widely thought that most of these idiopathic cases are actually viral. Common culprits are viruses like Coxsackie virus A and B and echovirus. Other causes exist too: bacterial, fungal, autoimmune, kidney failure, even certain medications.
And isn't there a specific type after a heart attack, Dressler syndrome?
Yes, exactly. Dressler syndrome is a specific form of pericarditis that typically shows up weeks, sometimes even months, after a myocardial infarction, a heart attack. It's thought to be an autoimmune reaction to the damaged heart muscle tissue.
Okay, now the big symptom for acute pericarditis. There's a really characteristic type of chest pain, isn't there?
Oh, absolutely. It's quite distinct. The classic chest pain of acute pericarditis is usually sudden in onset, sharp, and pleuritic.
Pleuritic meaning.
Meaning it gets worse when you take a deep breath or cough. It's typically felt in the front of the chest, often radiating to the neck or shoulders. But the real giveaway, the hallmark feature, is its positional nature.
Ah, the positional part. How does that work?
It classically gets significantly worse when the person lies flat on their back, supine. And often, quite dramatically, it gets better when they sit up and lean forward.
Leaning forward helps. Why is that?
Leaning forward physically pulls the heart slightly away from the inflamed pericardial sac against the chest wall and diaphragm, reducing the friction and pressure on those inflamed layers. It's a huge diagnostic clue.
That is such a specific and useful detail. And when a doctor listens to the chest, is there a particular sound they might hear?
Yes. The other classic physical finding is a pericardial friction rub. It's described as a scratchy, grating, or squeaking sound, sometimes like leather rubbing together.
A friction rub. Where do you hear it best?
Usually best heard at the left lower sternal border, with the diaphragm of the stethoscope pressed firmly. And again, having the patient sit up and lean forward can sometimes make it louder or easier to hear. It can be transient, though. Sometimes it comes and goes.
Okay, and for diagnosis, what's the main test you'd rely on?
The electrocardiogram, the ECG, is really the cornerstone for diagnosing acute pericarditis. It often shows very characteristic changes.
What kind of changes?
You typically see widespread ST segment elevation,
Yeah.
but unlike the ST elevation in a heart attack, which is usually localized and convex, tombstone-shaped, in pericarditis, it's usually diffuse, meaning across many leads, and often concave upwards, like a smiley face.
Diffuse concave ST elevation. Got it. Anything else on the ECG?
Yes, often you'll also see PR segment depression, which is also quite specific when present with the ST changes. These ECG findings are really helpful. An echocardiogram is also usually done mainly to look for any fluid buildup around the heart, a pericardial effusion, which can sometimes accompany the inflammation.
Right. So once you've diagnosed it, how do you treat acute pericarditis?
For most typical viral or idiopathic cases, the first-line treatment is usually high-dose NSAIDs like ibuprofen or indomethacin or high-dose aspirin. And very importantly, these are often given together with a medication called colchicine.
Colchicine. Why add that?
Colchicine has been shown to be really beneficial. It helps reduce the pain, shorten the duration of symptoms, and significantly decreases the risk of the pericarditis coming back, recurrence, which can be a problem.
So NSAIDs plus colchicine is standard. Are steroids ever used?
Glucocorticoids, or steroids, are generally reserved for cases that are severe, don't respond to NSAIDs and colchicine, or if there's a specific underlying cause like autoimmune disease where steroids are indicated. We try to avoid them otherwise as they might increase the risk of recurrence.
And what about for Dressler syndrome after a heart attack? Same treatment.
For Dresslers, aspirin and/or colchicine are preferred first line. It's generally recommended to avoid other NSAIDs in that specific post-MI setting, as there's some concern they might interfere with the healing process and scar formation in the damaged heart muscle.
Good distinction.
Hmm.
Okay, so sometimes the inflammation leads to fluid buildup, a pericardial effusion. What exactly is that?
Yeah, a pericardial effusion is simply an abnormal collection of excess fluid in the pericardial space between those two layers of the sac.
And what causes that fluid? Same things as pericarditis.
Often, yes. The causes overlap significantly with acute pericarditis inflammation leads to fluid leaking out. But effusions can also be caused by other things, like bleeding into the space after surgery or trauma, kidney failure, low thyroid hormone, or very commonly, malignancy. Cancer spreading to the pericardium is a frequent cause of effusions, especially large or recurrent ones.
And what symptoms might someone have with an effusion?
Well, if it's associated with acute pericarditis, they might have that typical chest pain. But if it develops slowly or isn't related to active inflammation, the main symptoms are often shortness of breath, maybe some fatigue or a feeling of fullness in the chest. If the effusion is large enough, a key finding on physical exam can be muffled or distant-sounding heart sounds because the fluid is insulating the heart.
Muffled heart sounds. Makes
Mhm.
sense. How do you diagnose it for sure?
Echocardiogram is definitely the test of choice. It's excellent for visualizing the fluid, estimating how much there is, and seeing if it's having any effect on the heart's function.
Any clues on the ECG or X-ray?
The ECG can sometimes show low-voltage QRS complexes, especially with larger effusions, as the fluid dampens the electrical signals reaching the surface. And in very large effusions, you might see something called electrical alternans.
Electrical alternans. What?
That's where the amplitude of the QRS complexes alternates from beat to beat. It's thought to be due to the heart physically swinging within the large fluid-filled sac. A chest X-ray might show an enlarged cardiac silhouette, sometimes described as a water bottle shape, but it's not very sensitive or specific, especially for smaller effusions.
Okay, echo is key. And the management for an effusion.
It really depends on the cause and the size, and whether it's causing problems. The main goal is to treat the underlying condition, the infection, the inflammation, the cancer, whatever it is. If the effusion is small and not causing symptoms, it might just be monitored. If it's large and causing symptoms like shortness of breath, or if there's concern, it might lead to tamponade.
Which we'll get to.
Right. Then a pericardiocentesis might be done. That's using a needle and catheter to drain the excess fluid from the sac, which can provide immediate relief.
Okay, which leads us directly to that critical complication. Cardiac tamponade. Sounds serious.
It is. Cardiac tamponade is a true medical emergency. It happens when the fluid pressure inside the pericardial sac builds up so high that it physically compresses the heart chambers, particularly the right side, which has lower pressure.
So it squeezes the heart.
Exactly. It prevents the heart from filling properly with blood during diastole. If the heart can't fill, it can't pump effectively. This leads to a dramatic drop in cardiac output and can cause obstructive shock and death if not treated quickly.
Now, it's really interesting. You mentioned it's not always about how much fluid there is.
That's a crucial point. The rate at which the fluid accumulates is often more important than the absolute volume.
How so?
Well, if fluid builds up very quickly, say from bleeding after trauma, even a relatively small amount, maybe just 150, 200 milliliters, can cause tamponade because the pericardium hasn't had time to stretch. It's non-compliant.
Okay.
But if the fluid accumulates very slowly over weeks or months, like sometimes happens with cancer or kidney failure, the pericardium can gradually stretch and accommodate a much larger volume, sometimes even a liter or more, before critical pressure is reached. The heart adapts up to a point.
Fascinating. So when that critical pressure is reached, what are the classic signs clinicians look for? I think I've heard of Beck's triad.
Yes, Beck's triad is the classic description, though it's actually not seen in all patients. It consists of 3 signs. 1, distant or muffled heart sounds, again due to the insulating fluid. 2, distended neck veins or increased jugular venous pressure, JVP, because blood is backing up trying to get into the compressed right heart. And 3, decreased systemic blood pressure, hypotension, because the heart's output is severely reduced.
Muffled sounds, high JVP, low BP, Beck's triad. Anything else?
Another really important physical finding is pulsus paradoxus.
Pulsus paradoxus. What is that exactly?
Normally, your systolic blood pressure drops slightly, just a few millimeters of mercury, when you breathe in. In tamponade, this drop becomes much more exaggerated, usually defined as more than a 10 mmHg decrease in systolic pressure during inspiration. It reflects the increased restriction on the heart's filling when you inhale.
Okay, an exaggerated BP drop with breathing. How is tamponade diagnosed and managed urgently?
If tamponade is clinically suspected, especially if the patient is unstable, diagnosis and treatment often happen almost simultaneously. An urgent echocardiogram is usually the first step.
What does the echo show?
It confirms the presence of the effusion, but crucially, it looks for signs of hemodynamic compromise specifically, diastolic collapse of the right atrium and right ventricle, showing they're being squashed by the pressure. The ECG might show those low voltage complexes or electrical alternans we talked about.
And the immediate management.
The definitive treatment is immediate pericardiocentesis, draining the fluid to relieve the pressure on the heart. This is often life-saving. While preparing for that, supportive measures like giving IV fluids to boost filling pressures or sometimes medications to support blood pressure might be used.
Drain the fluid fast. Got it. Okay, one last pericardial condition. Constrictive pericarditis. This sounds like a chronic problem, like the sac itself becomes the issue.
Exactly. It's often described as the heart being encased in a rigid, non-elastic shell, like a straitjacket. Constrictive pericarditis is a chronic condition where the pericardium becomes thickened, fibrotic, scarred, and sometimes even calcified.
So it loses its normal elasticity.
Completely. And this rigid sac prevents the heart ventricles from expanding and filling properly during diastole. It physically restricts diastolic filling.
What causes the pericardium to become like that? Scarred and rigid.
Well, pretty much any condition that can cause acute pericarditis can potentially lead to chronic constriction down the line as the inflammation heals with scarring. So, idiopathic or presumed viral causes are common in the U.S. Worldwide, tuberculosis is still a major cause of constrictive pericarditis. Other causes include previous heart surgery, radiation therapy to the chest, chronic kidney failure, or connective tissue diseases.
And what does this straitjacket effect look like clinically? What are the symptoms?
The most common symptom is usually dyspnea, shortness of breath, especially with exertion. Fatigue is also common, and patients develop signs that look very much like right-sided heart failure because the right ventricle can't fill properly. Things like elevated jugular venous pressure, those distended neck veins again, peripheral edema, swelling in the legs and ankles, ascites, fluid buildup in the abdomen, an enlarged liver, maybe nausea, and a really characteristic sign is Kussmaul's sign.
Kussmaul's sign. What's that?
Normally, when you breathe in, the pressure in your chest drops, and your neck vein should collapse slightly as blood rushes into the heart. With Kussmaul's sign, which is seen in constriction, the opposite happens. The JVP either doesn't fall or actually rises during inspiration. It shows the rigid right heart just can't handle that increased venous return.
Wow. A paradoxical rise in neck vein pressure. Is there a specific heart sound with constriction, like the friction rub with acute pericarditis?
Yes, there can be. It's called a pericardial knock. It's a high-pitched sound heard early in diastole, soon after the second heart sound, S2. It sounds a bit like an S3 gallop.
A pericardial knock, what causes it?
It's caused by the abrupt halting of ventricular filling as the expanding ventricle suddenly hits that rigid, non-compliant pericardial shell. It's the sound of the filling suddenly stopping. Knock.
Makes sense. How do you diagnose constriction? Imaging.
Clinical signs are very important. A chest x-ray might show pericardial calcification, which is quite specific if seen, but not always present. Echocardiography is key, looking for signs of restricted filling, septal bounce, respiratory variation in blood flow across the valves. CT or MRI scans are often even better at showing the actual pericardial thickening and calcification.
So imaging helps visualize the rigid sac. And the treatment for this. Can medications help?
Diuretics can help manage the symptoms of fluid overload, the edema and congestion, so they provide some relief. But they don't fix the underlying mechanical problem. Because it's a structural issue, that tight, rigid sac physically squeezing the heart, the definitive treatment is surgery.
Surgery to remove the sac.
Yes, a procedure called pericardiectomy or pericardial stripping. It involves carefully removing as much of that thickened, constricting pericardium as possible to free the heart and allow it to fill normally again. It's a complex surgery, but it's the only potentially curative treatment.
Wow, what an incredible journey we've taken from deep inside the heart with infective endocarditis, that microbial battle.
Right, focusing on the bugs, the valves, the diagnostic clues like Duke criteria, and those tailored antibiotic strategies.
All the way out to the heart's protective sac with pericardial diseases. Exploring that acute inflammation with its classic positional pain, the dangers of fluid buildup in effusions and tamponade,
Including Beck's triad and pulsus paradoxus.
and finally, that chronic constriction, the heart in a straitjacket needing surgical release. We've really covered the key features and why spotting them matters.
Absolutely. And hopefully this deep dive gives you, our listener, a much richer appreciation for cardiovascular health beyond the usual topics. It really shows how different parts of this amazing organ can be affected and the really diverse ways these problems can manifest.
Yeah, understanding these details, it empowers you, doesn't it, to grasp the why behind certain symptoms or diagnostic tests.
Definitely. And maybe here's a final thought to chew on. Consider how both infective endocarditis, a fight against external invaders, and constrictive pericarditis, essentially a battle against the body's own scar tissue, how both can severely impair heart function. It makes you think, how can the body's own healing processes, like scarring, sometimes lead to significant long-term problems? What does that tell us about the incredibly delicate balance within our own physiology?
That's a great point. A provocative thought indeed. We really encourage you to think about those specific signs we discussed, the Osler nodes, the Janeway lesions, that pericarditis pain relief when leaning forward, Kussmaul's sign. Recognizing these intricate signals from the body is, well, it's a powerful thing. Thanks for diving deep with us today.